Now, how about using this other tool in our armamentarium, that is brachytherapy, intraluminal brachytherapy? Can we boost patients with intraluminal brachytherapy and improve the local control rates? So the first study I would point to is this JASTRO study, because it has no chemotherapy. It randomized patients to 60 gray plus another, it randomized patients to 60 gray, external beam radiation, and a boost with external radiation to an additional 10 gray in 5 fractions, or brachytherapy 10 gray in 2 fractions. No difference in toxicity, no difference in overall survival. However, the cause-specific survival for lesions less than 5 centimeters was superior for the group that got intraluminal brachytherapy. In fact, it was almost double, 64 versus 32%. Now, what put a dampener on the brachytherapy studies was RTOG 9207. Patients were phase 2 study, 50 gray, cisplatin, 5 FU, 15 gray in 3 fractions was an intraluminal boost, later reduced to 10 gray in, 15 gray in 3 fractions, later reduced to 10 gray in 2 fractions. Excessive morbidity, excessive mortality, 8% mortality, 12% fistula rate, and so on. And that, despite the improvements in local control, the overall survivals were not really any different from the combined chemoradiation studies. So, just as Dr. Shaleen Kumar alluded to, can you use surgery to improve the therapeutic outcome? And these are the 2 studies he showed. The German study, T3, T4, N1 squames, induction chemo followed by chemoradiation with surgery or definitive chemoradiation to total doses of around 65 plus gray. And the end result was no difference in median survival, no difference in 2-year survival, improvement in local regional control. However, treatment-related mortality was 13% versus 3.5%. The French study, same study that Dr. Shaleen Kumar showed, again similar outcomes, no improvement in median or overall survival. And then if you look at a series of studies that have been done, either with surgery alone or chemoradiation followed by surgery, and compare them with chemoradiation across the board, and I have to state this is thoracic squamous cancer, accounting for nearly 90% of the patients included in these studies. When you look at that group, there was really no difference in overall survival between these 2 arms. But who benefits then from surgery? So the German study and the French study alluded to this. In the German study, the responders by clinical evaluation or barium swallow did not benefit from the addition of surgery. But if you were a non-responder and you were able to have an R0 resection, so there's 2 parts to it, not just a non-responder, but you had to have an R0 resection, your survival at 3 years was 32%, which was significantly better than the non-responders who went on to just complete radiation. So there may be some clues there. Can we use some modern imaging to select these non-responders? And I've shown this here. There are plenty of studies which tell you, yes, there is a PET response which correlates with a pathologic response. But this is data that is still emerging, needs to mature. And the caveat of PET, one of the caveats of PET is this. You can have a patient who has an excellent response, however, you can have a false positive uptake if the PET is done within a few days after completing the phase 1 of chemoradiation. So traditionally people have been waiting 4 weeks or so to do this PET evaluation. But that doesn't work well for a phase 1, and then if you want to go on to a phase 2 with a radiation boost, because you don't want to have that big a gap in your protocol. So I think we have to still await. I think it's still under study, under protocol, and I don't think we are ready to accept PET as a way to screen patients who would benefit from surgery versus continuing radiation.